is hip dislocation. Hip dislocation, the most common anterior acetabular wall that is going to get affected is the posterior wall, and because of which the posterior dislocation of the hip is more common as compared to anterior dislocation of the hip. So posterior dislocation of the hip, it is seen in case of dashboard injuries or trivial trauma, while anterior dislocation of the hip is seen in deceleration injuries or fall from a height. Attitude of limb in posterior dislocation of hip is farther position, that is flexion, adduction, and internal rotation, while in anterior dislocation it is in Faber position. The very important is in the posterior dislocation of the hip. In the medial border of the foot, it touches the bed, while in case of anterior dislocation of the hip, the lateral border of the foot touches the bed. The length of limb in farther position, that is the posterior dislocation, is short, while in anterior dislocation, the length of the limb lengthens. Then talking about the X-ray features. So in the X-ray features, the Shenton's line is broken. Then the head is palpated in the gluteal region, while in case of anterior dislocation, the head is palpated in the femoral triangle. The nerve injury is present in the sciatic nerve, while in the anterior dislocation, the nerve injury is present in the femoral vessels greater than femoral nerve, while the most common complication is the vascular necrosis of the femoral head. Now there is something called vascular sign of Marat. Vascular sign of Marat is that a femoral artery is palpated against the femoral head. Now this is not seen in three conditions, that is the posterior dislocation of the hip, developmental dysplasia of the hip, and femoral head displacement. Management is there are some close reduction that is done under general anesthesia, if not open reduction internal fixation. Maneuvers like Ali's maneuver, then Bigelow's maneuver, Stimson's and East Baltimore maneuver can be used. Now very important, in the posterior dislocation of the hip, the management, reduction of the dislocated hip is an emergency, as the longer the hip remains out, there are higher chances of avascular necrosis. Closed reduction, as I said, closed reduction is done by manipulation under the general anesthesia. Then the technique, the patient is anesthetized and placed in supine position. Assistant, the grab and place grabs the pelvis firmly, while the surgeon is the one that is going to flex the hip and knee at the right angles and give a avial pull like this. Usually a sound of reduction is heard. Then open reduction, it may be required in cases where the closed reduction fails or there is an intra-articular loose fragment which is not allowing the accurate reduction. Complications, as I said, is can be injury to the sciatic nerve. Myositis ossificans can happen, and for that you should give rest and analgesics. Avascular necrosis of the femoral head is the most common complication, and generally the features are seen 1 to 2 years after the injury. Clinical features that we pain in the hip and severely painless period after seemingly painless period of about a year. Then osteoarthritis is the latest complication. It is because of the vascular necrosis of the femoral head. For that, the total hip replacement is something that is done. Then talking about the proximal femoral fractures, where we have two important ones, that is neck of femur fracture and intertrochanteric fracture. So neck of femur fracture is an intracapsular fracture. So neck of femur fracture, mostly the distal segment displacement is common, which is proximal and externally rotated, right? But however, the distal segment displacement is limited due to the capsule. On the other hand, intertrochanteric fractures, the displacement is common of the distal segment, but it is more because it's an extracapsular fracture. Now, neck of femur fracture is found in 50 to 60, while intertrochanteric fracture is found after 60 years, 70 to 80 years. Both of them are common in females as compared to males because of postmenopausal osteoporosis. The neck of femur fracture is formed due to trivial trauma, while the intertrochanteric fracture is seen due to moderate to severe fall. Pain is mild in case of neck of femur fracture. It is moderate to severe in intertrochanteric fracture. The location of pain is Karp's triangle, while intertrochanteric is in the trochanteric region. In both of the cases, the shortening of the limb will happen. Shortening of limb will be less than 1 inches in neck of femur fracture. It is more than 1 inches in case of intertrochanteric fracture. And then external rotation is found in both of them. Here, the external rotation in the neck of femur fracture is less than 45 degree, while it is more than 45 degree in case of intertrochanteric fracture, because of which the lateral border of the foot it touches the bed. Then the complication, avascular necrosis or more than the non-union. Apart from that, osteoarthritis is a late complication, while in intertrochanteric fracture, malunion leading to coxa vara, it's complication. What are the causes of non-union? The causes of non-union is the presence of cambium layer as is the lack of cambium limb, then the presence of synovial fluid and the decreased vascularity in this. So the classification. So the first is the anatomical classification. So in the anatomical classification, the suboccipital, transcervical, and vesicervical are the three classifications. Out of which the suboccipital subcapital classification, it is most commonly associated with vascular necrosis, and on the basis of Powell's angle, it is 1 to 3. Powell 1 is less than 30-degree angle, more than 30-degree, that is 30 to 50 is called as Powell 2, and 50 to 70 is called as Powell 3. More the angle versus the prognosis. Gardner classification. So Gardner classification is divided into 4 stages. So first stage is where there is incomplete fracture and there is no displacement of the distal fragment. It is also called as impacted or abducted fracture. Type 2, there is a complete fracture but it is undisplaced, and type 3 is a complete fracture partially displaced, and type 4 is a complete fracture with complete displacement. Type 3 is where the distal segment is externally rotated, causing the internal rotation of the head of femur. Then talking about the mechanism. So first talking about the neck of femur fracture. So in the neck of femur fracture, as I said, the mechanism is a trivial fall. The patient can walk after a certain distance, that is very, very still possible with the neck of femur fracture. The clinical features, there will be pain, swelling, inability to move, and the patient with infected fracture can walk. Then the on examination, there is external rotation of the legs, then shortening, tenderness. Active leg rest test is not possible. On the radiological features, so X-ray features will be, there is a break in the medial cortex of the neck, so the Schnittgen's like will be break. The break in the trabecular lumen is present. Then overriding of the greater trochanter. There is a shortening of the limb, so this greater trochanter is located at a level greater than the acetabulum, and external rotation of the femur happens. Management. This fracture is also called as an unsolved fracture. Why it is called an unsolved fracture? Because there are high incidence of complications, and because of the above factors, the fracture needs to be invariably treated operatively so that these complications won't happen. The internal fixation, that is following the implants are used, that is either cancellous screws, these are the most commonly used, dynamic hip screw or no-lace pin can be used. So neck of femur management, if it's a displaced or impacted fracture, then conservative by Thomas Pin. Then if it's a displaced fracture, if the age is less than 65 years and if presents within 3 weeks, then close reduction internal fixation with cancellous screws is used. If it is more than 3 weeks, then we have to first assess on the MRI whether the head is viable or not. If the head is viable, we go for osteotomy operations like More's osteotomy and Powell's osteotomy. In non-viable patients, we go for Mears graft or Bakshis graft. Mears graft is a graft consists of arteritis femoris tendon, while in Bakshis graft it consists of pincer fascia lateral tendon. If it is more than 65 years, then you have to go for replacement. Now you have to assess whether there is arthritis or not. If there is no osteoarthritis, then partial replacement can be done, that is heavy replacement, and in case of osteoarthritis, total hip replacement can be done. So partial replacement consists of only head and neck, that is some osteoarthritis, prosthesis, bipolar prosthesis or Thompson's prosthesis, where in total hip replacement, it is along with the acetabulum. Then talking about the intratrochanteric fractures, they have a more pain in the groin region, swelling is more as compared to the neck of femur fracture. Also, the patient is not able to bear the weight over here. This is caused because of moderate to severe trauma. And the findings, there is a combination of the medial cortex, avulsion of the laser trochanter is seen on the X-ray, and similarly extension of the fracture in the subtrochanteric region. Management. The intertrochanteric fractures, they unite readily, and because of which we have to maintain the femoral shaft angle, otherwise coxa para deformity due to malleolin is present. Conservative methods that include the Russell's traction and the skeletal traction in Thomas Flint. Prolonged bed rest for 3 to 4 months is asked and may cause complications due to recombency, the bed sores, pneumonia, etc. Operative methods. Operative methods is the fracture is reduced under the X-ray control and fixed with internal fixation devices. So the most common internal fixation devices that are used are the dynamic hip screw. Then it consists of proximal femoral nail, Ender's nail, and the Palmer's nail. External fixation is used for patients with bed sores. Complications. The most common complication is the malleolin leading to coxa vara. For management of coxa vara, we go for intertrochanteric osteotomy. Osteoarthritis, in the early stage we go for physiotherapy, and in the late stage, if it's a young patient, trochanteric osteotomy, and only total hip replacement is done. Fracture of patella. So fracture of patella, there can be different mechanisms such as direct mechanism is the blow to the anterior aspect through the road traffic accident. But most of commonly this fracture of patella is a communicated fracture that is called as the stellate fracture. Indirect fracture of patella, it can happen due to violent contraction of the quadriceps muscle. That can because of which there can be a two-part fracture. That is a fracture line runs transversely between the two parts of the patella. Now the pathanatomy is that it is usually displaced because the prepatellar expansion of the quadriceps tendon takes place and the patellar retinaculum on the both sides. So usually it is undisplaced, but in two-part fracture it becomes displaced. Clinical features is pain and swelling over the knee joint. Patient is not able to bear the weight on the limbs. That is basically extensor lag is seen. Patient cannot have a knee with full extension. In comminuted fractures, there is crepitus spread, and in displaced fractures, a gap can be seen. Radiologically, anteroposterior view and lateral views are sufficient, but sometimes a skyline view may be required in undisplaced cases. Management of undisplaced fracture, we have to give analgesics, and a plaster cast is applied. That is called as the cylinder cast. Cylinder cast, it comes from the groin up to the medial malleolus. With knee in the full extension, and it should be kept for 3 weeks. And then the two-part fracture, if it's a two-part fracture, then the open reduction internal fixation with tension band wiring is required. If the reduction is not possible, then you have to go for patelectomy. Now, if one fragment is gone, in that particular case, partial patelectomy is done. All operations are followed by support in cylinder cast for 4 to 6 weeks. This is must. And if it's a comminuted fracture, in that case, patelectomy should be done. Then the complications, it will lead to knee stiffness is the most common complication for which physiotherapy is needed. Extensor weakness is present. Next is the fracture of the shaft of tibia. So fracture shaft of tibia, again the mechanisms are direct and indirect. So direct, there is a road traffic accident that will lead to blow to the tibia. Generally the object causing the fracture, they lacerate the skin over it, and most of the times this fracture of the shaft of tibia, it's a open fracture. Now the indirect fractures can be the bending force that will lead to oblique fracture. There is a torsional force at the tibia that will lead to spiral fracture. The sharp weight of the fracture within it may pierce the skin to make it an open fracture. Then the displacement are given by this mnemonic is SAR, that is a sideways, angulated and rotational displacement is present. The clinical features, there is a history of trauma, then pain, swelling, deformity, and wound communicating with the underlying wound. Diagnosis, the X-ray is AP view and lateral view. Now it is a closed fracture, right, and it is undisplaced. Then POP cast is used for 4 weeks and followed by a patellar tendon bearing cast for 6 weeks. So 4-week POP cast followed by PTP cast for 6 weeks. If it's a displaced fracture, then and if the patient is stable, then closed reduction is done under general anesthesia. If closed reduction if found to be satisfactory, that is, you have to check it after every week for the first 4 weeks. If the position is maintained, then you have to continue with the POP cast for 4 weeks and then followed by patellar tendon bearing cast for 6 weeks. If it's non-satisfactory in nature, then you have to do a closed nailing. And if the patient is unstable, then closed nailing or open nailing of the fracture is required. Now it's an open fracture. Now as I said, most of the fractures of the tibia, they are open because of skin laceration above. So if there's in the grade 1, we have to do the wound debridement. In the grade 2, wound debridement along with primary closure and external fixation. In grade 3, wound debridement is done, dressing is done, and external fixation. Apart from that, next we apply a POP cast followed by a patellar tendon bearing cast. Nowadays, open reduction internal fixation is preferred. Now there's something called as the wedging. So what is wedging? It is done for fractures which show angulation, and because of which the plaster cast is cut circumferentially on the concave side of the angulation so as to maintain the length. Now very important is the technique of close reduction. So under anesthesia, the patient lies in supine position with the knee flexed over the end of table. Now the patient is kept in traction using the halter, which is made up of bandage. What are the complications? So the complications are the delayed union or the malunion, right? And apart from that, infection or compartment syndrome can be the complication of the fracture of tibia. Next, about the infections of the bone. So in infections of the bone, there is going to be osteomyelitis. So acute osteomyelitis, the most common site is around the knee joint. It is the lower end of the femur and the upper end of the tibia. In the adults, it is going to be the thoracolumbar vertebra. And the most common spread and the primary cause for acute osteomyelitis is going to be hematogenous spread. What is acute osteomyelitis? It is nothing but infection and inflammation of the bone along with bone marrow. Then there is a classification called as a Wald-Vogel classification, where less than 2 weeks with acute, then 2 to 4 weeks with some acute osteomyelitis, and more than 4 weeks, that means chronic osteomyelitis. The etiologies are the different causative factors. So Staphylococcus aureus is the most common causative factor. It is found in immunocompromised patients. It is common in the competent people as well. Less than 4 years, it is Haemophilus influenza B. In drug abusers, there is going to be Pseudomonas. For human bites, it is going to be Eikenella. For animal bites, it is Pasteurella. For sickle cell anemia, it's Salmonella. And for parenteral therapy, it is fungus. Now, the mechanism. So there are two theories, that is Hobo's theory and Truetta's theory. So Hobo's theory says that there is a lack of macrophages within the metaphyseal region of the bone, and Truetta's theory says that there is a looping of the vessels in the metaphyseal region, and because of which there is going to be sluggish blood flow over here. So the organisms reach the bone via the blood circulation. They get lodged into the metaphysis. Bone initiates the inflammatory reaction, and there is bone destruction that happens in 7 days. Pus formation that happens in 2 to 3 days. Now, this spread of pus is present along the medullary cavity, leading to thrombosis of medullary vessels. Out of cortex, it's going to lead to dead dens and destruction of the bone, that is called as the sequestrum, and a new bone formation, that is subperiosteal reaction, that will be seen at around 7 to 10 days on X-ray. Now, it can also affect epiphysis in children less than 2 years, because the growth plate is not formed properly, and because of which the limb shortening can be present. Now, the clinical feature presents as pseudoparalysis. What is pseudoparalysis? So basically, the child is not able to have the limp, as it is not able to bear the weight. So the pseudoparalysis is seen in scurvy. It is found in acute osteomyelitis and syphilis. Then another features will be fever, swelling, and the examination. The child is febrile and dehydrated. In investigations, the polymorph level will be increased in limited ASR. On the X-ray, the earliest side is the periosteal reaction, that is found by 7 to 10 days. On the bone scan, as technetium 99, it may show increased uptake by bone in the neutrophils. Indium 111, it labeled leukocyte scan, is more specific for the diagnosis of bone infections. The differential diagnosis: acute septic arthritis, acute rheumatic arthritis, and scurvy. Now, very important, the management. So the management, if the child is brought within 48 hours of the onset of the symptoms, then the pus is not formed, so the limb is put to rest. If the child, generally the most common source of infection is Staph aureus, because of which we give cloxacillin and fusidic acid. If it's a salmonella, we give cotrimoxazole. So streptococcus pneumoniae penicillin. If the children is less than 4 years, it is because of Haemophilus influenza, we give ceftriaxone. The older children also give ceftriaxone. So these empirical antibiotics are started. Antibiotic culture and sensitivity report is awaited, so that the specific antibiotics can be delivered. The child is adequately hydrated, immobilized, and the weight bearing is restricted for about 6 to 8 weeks. Surgical intervention is required if the patient does not respond favorably to the antibiotics within 48 hours. Now, if the child is brought after 2 days, that is after 48 hours of the onset, then the pus formation has taken place. So we have to go for surgical exploration and drainage of this pus. The ultrasound examination of the affected part of the drill hole is made in the bone in the region of metaphysis. The hole is enlarged until a free drainage is obtained, and then the swab is taken for culture sensitivity. The rest antibiotics and hydration are continued post-operatively, and antibiotics are continued for 6 weeks. Complications: generally it leads to septicemia or pyonia, and localized it can further progress to forms of acute osteomyelitis, chronic osteomyelitis, arthritis, or growth plate disturbances that will lead to shortening or deformity of the limb. Now, subacute osteomyelitis consists of Brodie's abscess, which is more common in case of knee. And Gary's abscess is a dry abscess, and it is seen in case of jaw most commonly, and typhoid osteomyelitis, which is more common in the ulna greater than the rib. Now, talking about the next, that is chronic osteomyelitis. So, the chronic osteomyelitis is also called as chronic pyogenic osteomyelitis. Apart from that, other causes can be linked to TB or fungal infection. Then, Gary's osteomyelitis or Brodie's osteomyelitis also considered to be a chronic osteomyelitis. The most common cause of chronic osteomyelitis is, however, going to be the Staph aureus. The most common cause in foreign body implant is going to be the staph epidermidis. Then there is something called as the Wallenkamp phenomenon is seen, that is waxing and waning patterns. The fever, swelling and pain is going to increase and increase, and on one fine day the swelling bursts, and because of which this fever, swelling and pain is going to fall down. Pathognomy for this is the chalky white material coming out of the bone chips that are formed. Then pathophysiology, the persistent infection because of which pus is formed that will lift us periosteum, and because of which the blood supply is cut off, and this will lead to the dense, dead and devascularized bone, that is sequestrum. Now this sequestrum is then contained with the help of subperiosteal new bone reaction, that is called as the involucrum. So involucrum is going to contain this. Then there is a hole in the involucrum that is called as cloaca, and through the cloaca this infection will be transferred out, and then there will be a formation of a sinus, that is sinus where it is formed at the level of skin, and from which this infection comes out of the skin. Then sequestrum is a piece of the dead bone. It is surrounded by the infected granulation tissue. Try to get this sequestrum away. It's a dead, dense and devascularized structure. It has smooth inner surface and a rough outer surface. Paprika size is found to be negative, and it is pale white in color. Now when you talk about this sequestrum, there are different types of sequestrum. So the pencil-like sequestrum is found in infants, conical sequestrum in amputation stump, coralliform in Perthes disease, ring in pill tract, then feathery in syphilis, and fine sandy in viral osteomyelitis, then coarse sandy in TB osteomyelitis, green in pseudomonas, and black in fungus. Now if you talk about the sinuses, then the DB sinus is bluish discolored underlined edges, and hypostatic or anesthetic walls are present. Complaints, the patient will complaints of chronic discharging sinuses. The sinuses, the upon heal and reappear. Pain is minimal, and there is a fever that is present. Examination of this chronic discharging sinuses, the sequestrum may be visible. The bony chips or chalky white discharge can be seen, and adjacent joint may be stiff or extensive. Scarring in soft tissues is present. Now, investigations in the X-ray will find thickness and irregularity of the cortices. Patchy sclerosis is seen. Then there is a dense dense material surrounding the normal bone, that is involucrum, and the penumbra size is seen, that is a thick sclerotic ring of outside a radiolucent material. Then cyanogram, which is a radiopic dyes injected in X-ray, is taken, and CT scan, MRI can be also done, bus culture can be obtained. And the management principles is the treatment is surgical, removal of the dead bone, and elimination of the dead space and the cavities is done. So the operation procedure is called a sequestrectomy and saucerization. So sequestrectomy is the removal of the sequestrum, and then saucerization is where the shallow cavity, where the hollow cavity is converted into a shallow cavity, because of which the persistence of infection won't take place and the recurrence of infection won't take place. Then the dead space management is done. Dead space management, it consists of filling it with PMMA, bone graft, muscle graft. It should not be filled with metals. The different techniques are the VAC therapy. I stands for Lazaro technique, M stands for Masculine technique, and P stands for Papillon-Friedl's technique. Apart from that, there is excision of the infected bone. Curettage happens. Curettage of the infected granulation tissue takes place, and finally amputation is recorded. In very rare cases, long-standing sinuses are present. Then after surgery, the wound is closed over a continuous irrigation system, right? And a slow suction is applied to the outer tube, so that all this irrigation fluid that is given in consists of suitable antibiotics, and all that granulation tissue is irrigated out. Then the complications are acute exacerbation or flare up of the reaction. Then growth abnormalities can be seen, shortening, deformity, lengthening, pathological fractures such as joint stiffness. Apart from that, sinus tract malignancy, that is called as epithelioma, can be seen. Next is the fracture of the pelvis. So fracture of pelvis is classified by the Tiles classification into whether it involves the pelvic rim or not. If it involves the pelvic rim, then that's unstable fracture. If it doesn't involve, that's a stable fracture. The examples of stable fracture, the Duvernay's fracture. If there's isolated fracture of the iliac wing, and if there's isolated fracture of the ischium. Then if it's a unstable fracture, it has got further classification, it is Young and Butter's classification. So first is open book fracture, wherein it is horizontally unstable, and this is caused because of anterior posterior decompression. Then lateral decompression fracture, there is a Malgagny's fracture, where the ipsilateral superior pubic ramus as well as ipsilateral iliac sacroiliac joint disruption takes place. If there is ipsilateral superior and inferior pubic ramus getting affected, contralateral sacroiliac wing getting affected, and that is called as the bucket handle fracture. And in complex fracture, both the rami are getting involved. That is called as straddle fracture. The consequences of it, or the complications of pelvic fracture, the most common is urethral injury. Bleeding can happen, which is a dangerous complication, because of which we have to do external compression. Bed sheets or pelvic bandages should be used, and internal compression with the help of pelvic tamponade. Then the next is the pelvic fracture complications. So the most common, as we have discussed, it's the rupture of urethra. So whenever there is a rupture of urethra, there is a bleeding per urethra and pain in that region with a distended bladder. Management is, because the bladder is distended, we have to remove all the contents, that is done by suprapubic cystectomy or cystostomy, and assess the severity using a micturating cysturethogram. Then next is the rupture of bladder can happen if there is a over distension of bladder further, that can lead to rupture of bladder. Diagnosis is made by cystourethrogram, and here you have to drain the urine in the prevesical space. Then injury to the rectum or vagina, injury to the nerves. The nerves of lumbosacral plexus are the most common affected. Injury to major vessels, that is common iliac artery. Then the rupture of diaphragm can happen as well. Now next infection is going to be the tuberculosis. So the tuberculosis, we are going to talk about the TB of the spine and the TB of the hip. Now very first important thing, that is the TB of spine. Spine is the most common bone that is involved in TB. Right, agent is Mycobacterium tuberculosis. Obviously, this is not a primary site of infection. The primary site of infection is the pulmonary. This is going to be secondary to it, and spreads by the hematogenous roots or the Bacillus plexus of veins, which is paravertebral plexus. Bacteria, it lodges in the contiguous areas of two adjacent vertebrae. That will lead to granulomatous inflammation, erosion of the margins. The disc degeneration takes place, and eventually the disc destruction, and that will lead to collapse of vertebrae. Collapse of vertebra will lead to the formation of cold abscess. The types of it are paradiscal type, which is the most common type of tuberculosis of the spine. Then the clinical features, there is a back pain, which is the presenting complaint, stiffness, cold abscess, it presents as a swelling, paraplegia, deformity, and constitutional symptoms like fever or weight loss. Examination gait, so the short steps are used to avoid the jerking the spine, and attitudinal deformity, stiff straight neck, kyphos or gibbous formation because of vertebral collapse and spinal TB, and the paravertebral swelling is seen, and that is fluctuant, that is cold abscess. So talking about the investigations is going to the X-ray. The reduction of the disc space is seen, that is the earliest sign. Destruction of the vertebral body, evidence of the cold abscess. So there is going to be paravertebral abscess. This is fluctuant in nature, and is called as the bird nest abscess as well. Then apart from the retropharyngeal abscess, source of abscess, source abscess can be seen, which are the evidence of cold abscesses. Then talking about the vertex above and below the lesions, there is going to be diffuse rarefaction that is seen. In the CT scan, the abscesses can also be visualized, while the investigation of choice for TB spine is going to be the MRI, where the type and extent of the compression is seen. If it is still not understood, then biopsy can be done, otherwise CBC, ASR, ELISA can be performed. Management principles is to achieve the healing and prevent, detect and treat the patients promptly. So medical therapy consists of anti-tubercular therapy, HRCD and HRE. HRCD is given for continuous phase of intensive phase for 2 months, and a continuation phase for 9 to 18 months. Care of the spine. So rest to the spine should be given during this phase. Now this rest to the spine can be given by a jacket called as the Minerva jacket, or a collar, or a body cast can be used in case of children. Now mobilization, the patient is allowed to sit and walk. If he improves, the spine is supported by cervical swallow spine, or ash brace can be used for dorsal lumbar spine. The patient is not allowed to for sports for about 2 years. The treatment of cold abscess, so aspiration and evacuation of the abscess is important. Aspiration should be done by anti-gravity insertion of the needle, and evacuation of the cold abscess is done, and the wound is closed without a drain. Complications that can lead to abscess and neurological compression. Now if the neurological compression happens, then that is called as Pott's paraplegia. So Pott's paraplegia is nothing but TP spine with neurological involvement. Now, pathophysiology, there can be a lot of inflammatory edema, and because of which the neural tissues they get compressed. Extraneural pus and granulation tissue is the most common cause of compression. Now, the types of Pott's paraplegia are early onset and late onset. Early onset is seen during active phase, and late onset is seen several years after the disease has become quiescent. So, in the early onset, where the causes are going to be the granulation tissue abscess or the infective thrombosis of the spinal blood supply. In late causes, it can be the recurrence of disease, then the fibrous septae following the healing, and the severe kyphosis. It is given. Now, talking about the grades of Pott's paraplegia, in grade 1, the patient is unaware of its deficit. However, when we do the neurological examination, the Babinski size is found to be positive, or ankle or patellar clonus is present. In grade 2, the patient is now becoming aware there is incoordination or spasticity while walking, but however, the patient can walk with support. In grade 3, there is a severe weakness, paraplegia and extension, and there is a partial loss of sensation. In grade 4, there is a paraplegia infection, there is a nearly complete loss of flexion. Clinical features is muscle weakness, loss of sensation, paraplegia and extension, inflection, and complete loss of sensation. Then investigation X-ray can be done for kyphus or gibbus. Then for MRI, we can know the type of vertebral destruction as well as extent of it and cause of paraplegia. And management of receivers are promote the recovery of the affected tissues and achieve the healing of vertebral lesion. Conservative management is antitubercular therapy, rest, and using of ash bracing for 6 to 12 months, or whole body cast in case of children. Then uh, operative treatment, it consists of those patients where the conservative management fails or where the sensory loss is present for more than 6 months. In that case, costotransversectomy is done, or anterolateral decompression of the spine is done, or there is a Hong Kong operation. This is radical debridement thoracic, or laminectomy can be done. Then the next is tuberculosis of the hip. So in the tuberculosis of the hip, there are three phases: SAE, SAE. So stage 1 is the stage of synovitis. In the stage of synovitis, there is effusion into the joint, and deformity is the fiber, and the stage of apparent lengthening, while the pelvis is tilting in downward direction. Stage 2 is the stage of arthritis. In the stage of arthritis, there is involvement of the articular cartilage. Here, the position is in the father position, while it's the stage of apparent lengthening again. The pelvis, however, here tilts upwards. Stage 3 is the stage of erosion, where there is complete erosion of the articular cartilage that has taken place. Again, the position is father, and there may be pathological dislocation, subluxation of the hip, or deformities, and this is the stage of true shortening is present. Management is general care of the hip, and operative management, that is girdle stones, arthroplasty, arthrodesis, corrective osteotomy, so the total hip replacement is done. Then talking about the next thing, that is congenital adipose equinovarus or the clubfoot deformity. It is a first born male child, 1:1000, and it is seen in patients with breech delivery. It is more often bilateral. Then the pathophysiology is that there is a hypoplastic talus, and that will lead to talonavicular dislocation and contracture of the trapdoor Achilles and the posterior tibialis muscle. Congenital, it is mostly idiopathic in nature, then associated neural tube defects like spina bifida, and this arthrovirosis multiplex congenita. Acquired, it is associated with poliovirus. Then the deformities that given by this mnemonic cave, so the cavus because of medial arch, adduction because of the metatarsals, and then there is a varus because of the subtalar joint, and the equinus at the level of ankle joint, that is calcaneonavicular joint. Along with that is internal rotation of the tibia, that is Lamline test. Now the screening test. The screening test is dorsiflexion. The toe doesn't touch the shin of the tibia. Investigation of choice, the Keitts angles. Normal Keitts angle is 20 to 40 degree, which is less than that, that is CTB. Ponseti's method is used for the management, where we have to start the management from the 2 weeks itself. The order of correction is in the cave, and manipulate by using a POP cast every week. We have to manipulate it for 7 to 8 weeks, and above new POP cast. If there's overcorrection, that will lead to rocker bottom foot, and where the congenital vertical dialysis present. To prevent the recurrence, these Davis splint is used. That is called as the Davis Brown splint. Till the baby starts to walk. After the baby starts to walk, there is a special CTV shoes which consist of the straight inner border to prevent adduction, which does not have any heel to prevent the equinus, and a raised lateral border to prevent the varus. Once the baby starts walking, 3 to 5 years, it is advised, and it should be advised for 23 hours a day. Then for 1 to 3 years, there is a posterior medial soft tissue release operation, and a Ponsonby's procedure is done, that is called as the Turcot's procedure. Then 3 to 5 years there is PMSTR, that is posterior medial soft tissue release, along with Tilbury-Vance procedure. Then for 5 to 8 years the varus becomes bony, and for that the Dwyer's procedure is carried out. For 8 to 10 years which transectomy can be done. For 10 years, after 10 years there is triple arthrodesis, that is the talonavicular, talocalcaneal and the calcaneocuboid joint. They are attached to each other. Then chest, that is Ushi's external stabilization system, or thorough stabilization can be used. Then another important pathology that is called as the DDH, that is developmental dysplasia of the hip. It is found in firstborn female child. It also has a propensity of 1 in 1000. It is more on the left side as compared to bilateral, while CTV is more of bilateral, 50%. Now the pathophysiology. The pathophysiology is caused because of a shallow, flat or a convex acetabulum. Clinical features is difficulty in removing the diapers of one hip, or there is a click sound while removing it. Then there is excessive thigh or the gluteal fold. Limb shortening is present, and vascular sign of Marath is positive. What is the test? There is a Barlow's test. Barlow's test is bad because that leads to adduction of the hip, and there will be even more dislocation. Ortolani's test is good because abduction, and that will lead to fixation. Ali sign and Galeazzi's sign, where we compare both the limb signs. This is used for unilateral DDH. In case of bilateral DDH, Gislet test is used. It shows Straddle gate as well. Investigation of choice is MRI, and screening ultrasound is less than 6 weeks. Now here are X-ray radiological features. In the X-ray radiological features, there are two lines. It is called as Perkins line and Hillgren's line. Hillgren's line H for H, that is horizontal in nature, and Perkins line is vertical in nature. Now this generally the femoral head, it lies in the lower inner quadrant. If the femoral head, it lies in the upper outer quadrant, and that is the case of DDH. Third is the management. If it's for 0 to 6 months, the Pavlik harness is used, or von Rosen splint. For 6 to 18 months, corrective osteotomies are done. For 18 to 30 months, again osteotomy. More than 3 years, pelvic osteotomy is done, and for more than 10 years, the total hip replacement is advised after skeletal maturity. So when we talk about a POTS fracture is basically a fracture of the fracture dislocation of the ankle joint. The mechanism is going to be a bending or twisting injury to the ankle joint. Now classification, it is called as the Lodge-Henson classification for POTS fractures. In the Lodge-Henson classification, the first is the adduction injury. So whenever there is adduction injury, there is oblique fracture in the medial malleolus, while in the lateral malleolus there is avulsion fracture. Tibiofibular syndesmosis is normal. In abduction injury, there is going to be avulsion fracture of the medial malleolus. In the lateral malleolus, there will be a fracture at the ankle mortise, while when the tibiofibular syndesmosis is normal. The third is in the pronation, when the external rotation happens. So the patient is pronated and the external rotation happens, and that will lead to transverse fracture of the medial malleolus. Then in the lateral side, it will lead to spiral fracture of the fibula, and tibialofibular syndesmosis is damaged. While if within the supine position the patient is externally rotated, that will lead to transverse fracture of medial malleolus again. But however, on the lateral side, this will lead to spiral fracture of lateral malleolus. This is very important. While tibiofibular syndesmosis is normal, while there is a fracture of posterior malleolus as well. In vertical compression, because of fall from a height, there will be multiple communicated fractures of medial malleolus, lateral malleolus, as well as the distal ring of tibia. Clinical features, obviously pain, swelling, tenderness at the level of ankle joint. Then history of twisting injury will be present, crepitus will be present. Radiologically, the X-ray of the ankle joint is done in the AP and the lateral view. You will find a fracture line in the medial and lateral alveoli. Tibiofibular syndesmosis is seen, and posterior malleolus is also seen. And management, if it's a fracture without displacement, then in that case we mobilize the ankle joint by below knee POP cast or plaster cast for 3 to 6 weeks. It's a case of fracture dislocation that has happened. Then the conservative measures is close reduction under general anesthesia. Below knee plaster cast is used. Check with X-ray if satisfactory alignment is present. For 8 to 10 weeks, the cast is kept in place. Then operative methods. Operative methods is open reduction and internal fixation. So this is very important. In these, what are the different techniques for medial malleolus? Now, medial malleolus, there can be oblique fracture in adduction injury. For that, the compression screws are used. Avulsion fracture is seen in abduction injury. Then that tension band wiring is used. And there is a transverse fracture that is seen in case of external rotation injury, where compression screw as well as tension band wiring can be used. In lateral malleolus, there can be avulsion fracture. In that avulsion fracture, the spiral fracture. The spiral fracture is present in case of external rotation pronated, supinated. So in that particular case, compression screws are used. Transverse fracture, tension band wiring is used. For comminuted fractures, buttress plating is used. At a lower end of fibula fracture, that is seen in pronated position, external rotation for that plate is used. Then posterior malleolus. In the posterior malleolus, this is getting damaged only in case of external rotation in the supine position, in supinated position. For that, the compression screws are used. Tibiofibulus syndesmosis damage that is seen in pronated position, external rotation, where long screw is used that extends from the fibula to tibia. Then the complications. The complications, there will be stiffness of the ankle joint and osteoarthritis that will happen. Now talking about this particular thing, that is osteoarthritis. Osteoarthritis is a degenerative joint disease. Right? Primary osteoarthritis occurs in de novo joint, and this is generally seen in old patients in weight-bearing joints. The most common joint that is involved is the knee joint in Asian population, while in Western population is the hip joint. Apart from that, the metacarpal joint as well as the interphalangeal joints can get involved. Then the secondary, there is underlying primary disease of the joint which leads to degeneration. The causes of this: in the hip joint, the causes can be vascular necrosis, developmental dysplasia of the hip, coxa vara, malunited fractures. In knee joint, it can be the condylar fractures of the femur, patellar fractures. There is a pathology. The pathology is that there is increased water content and depletion of the proteoglycans. Because of the decreased water content and the proteoglycans, and the repeated weight bearing on such cartilage will lead to fibrillation. Further rubbing will lead to subchondral bone. It becomes hard and glossy. At the bony margins, there forms a ring of projecting spurs that is called as osteophytes. The formation of subchondral cyst and sclerosis, that is a new bone formation, is seen, and a loose flex of cartilage, they are present, and that will lead to deformity and stiffness. Now, clinical features: it occurs more commonly in case of elderly population, frequently bilateral, and knee joint is more commonly associated in Asian living habits, while in Western living habits, the hip joint is affected. Pain is the earliest symptom. Then stiffness initially due to pain and muscle spasm, while later it can lead to contraction. Then examination, there is going to be tenderness, crepitus, swelling, pain, deformities. Right? In the knee, it will lead to varus deformity. In the hip, it will lead to fiber deformity, that is flexion, abduction, external rotation. Then terminal limitation of the movements or subluxation can be seen. Investigations. In investigation, very important, osteoarthritis, there is a narrowing of the joint space. Apart from that, subchondral sclerosis, that is new bone formation under the articular cartilage, subchondral cysts, osteophytes, these are nothing but the bone margins can be seen, or the loose bodies inside the synovial fluid can be seen. Then other workup is RA factor for rheumatoid arthritis, serum uric acid for acute gout, for arthroscopy. Management principles are delay the occurrence, then stall the progress of the disease, or rehabilitate the patients. The methods that are used are analgesics, long-acting formulations are preferred, and counterprotective agents like the glucosamine and chondroitin sulfate are used. Viscosupplementation is by using sodium hyaluronate, and supportive therapy is by weight reduction, avoidance of the stress, local heat, and exercise to build the muscles. Surgery that can be done in case of coxa vara, intertrochanteric osteotomy can be done in case yes, and in genu varum, the high tibial osteotomy can be done, and joint displacement and joint debridement can also be performed. Next is the rickets. So rickets, it can be divided into type 1 and type 2. Type 1 is because of vitamin D, type 2 is because of phosphates. So type 1, it is because of the deficiency of vitamin D or due to disturbance in the vitamin D metabolism. Type 2, it can be because of the defective absorption of the phosphates through the resulting or diminished intake or absorption of the phosphates. Now the clinical features that will lead to craniotabes. So craniotabes is seen in case of young patients. And when we apply the pressure over the skull bones, then that will compress and get released like a ping pong ball. Pausing of the frontal and the parietal lobes, broadening of the ends that is generally found in the wrist and the knee, delayed tooth erection. Harrison sulcus is the prominent depression, that is horizontal depression, that is found corresponding to the insertion of the diaphragm. Then the pigeon chest deformity where the sternum is prominent, rachitic rosary at the costochondral junction. Then muscular hypotonia where the abdomen becomes protuberant, pot belly is seen, and deformities, that is bow legs or knock knees, can be seen. The radiological features that consist of the delayed appearance of the epiphysis and widening of the epiphyseal plates. In the metaphysis, it leads to cupping and splaying, and in the diaphysis, it leads to rarefaction of the diaphyseal cortex. Medical management is vitamin D 6 lakh international units and a maintenance dose of 400 international units per day is given. The orthopedic management includes the mermaid splints or the orthopedic shoes can be used. Now talking about the hip deformities, there are two important hip deformities, the slip capital femoral epiphysis and the Burt's disease. Both of them they present with coxa vara. And the clinical features for them is going to be the breaking of the Shenton's line. Apart from that, the shortening of the limb, the obligate external rotation, problem in adduction and internal rotation, abduction and internal rotation, and the Trendelenburg gait is seen. So coxa vara, it can be either the normal leg shaft angle is 120 to 135 degrees. If it is less than 120, it's coxa vara. More than 135 degrees is coxa valga. Now, the congenital conditions that will lead to Fairbairn angle, while in secondary or acquired conditions, either slip capital femoral epiphysis or Perthes disease. Now, slip capital femoral epiphysis, the most common cause is idiopathic, associated with congenital hypothyroidism and endocrinopathy, and hypogonadism, because of which the sex hormones they help in growth plate fusion, and increased growth hormone, that is helps in increase the size of germinal plate. Now, the slip capital femoral epiphysis is a type of Salter Harris classification type 1. It is more common in males, bilateral 40%, and weight for age increases. Age of presentation is puberty. Clinical features is gynecomastia is seen, boy with a girly voice, obesity, and coxa vara is seen. Apart from that, in the X-ray, if you look, there are two lines. There is Kleene line. The Kleene line is the one that passes from the neck of femur. It is actually going to intersect the head, but if it does not, then that is Strathovan sign, which is characteristics of sleep capital femoral epiphysis. Now, the Perthes disease, the most common cause is idiopathic, associated with proteinase deficiency. Less than 4 years, the blood supplies by the fibular artery, while more than 10 years, the blood supply to the head or the capital region is via the middle circumflex femoral artery. And this Perthes disease is generally affected in 4 to 10 years. Investigation of choices. The MRI, there is a painless limb, or there is the child is normal throughout the day, and then at the evening there is going to be radiation to the knee and the groin. The management for Perthes disease is a broomstick cast or a Petrie's cast, and avoid the weight bearing. Next is the shaft of femur fracture. So the shaft of femur fracture, the proximal fragment, it undergoes fiber deformity. Classification is the Winquist and Hansen. Mechanism of injury is the high velocity road traffic accident or the fall from a height. Management, conservative management, there is a Thomas splint, and for definite management, there is going to be clinical close direction, internal fixation with the help of intramedullary nails. For Thomas splint, the inner diameter is the circumference plus 2 inches, while the length is the total length of the limb plus 6 inches. The complication is the most common, that is the stiffness of the joint, non-union. Most rated complication is fat embolism syndrome, wherein RNC is going to be the major criteria in the GERD, and other criteria, that is the minor criteria, is going to be tachycardia, fever, thrombocytopenia, anemia, fat globules in the urine and the sputum, and retinal hemorrhage. At least 2 major criteria or 1 major and 4 minor criteria are required. Management is damage control orthopedics. For less than 6 months, public harness is used, or von Rosen splint. For 6 months to 5 years, we go for hip spica cast. For 5 years to 10 years, titanium elastic nail syndrome or TENS is used. If the child is more than 10 years, then open reduction, internal fixation, intramedullary nail. Earlier, Kunsher nails were used. Gallows traction or Bryant's traction is present in child less than 2 years of age. Next is osteoporosis. So osteoporosis is a metallic bone disease which is characterized by diffuse reduction in the bone density due to decrease in the bone mass occurring when the bone resorption exceeds the bone formation. So pathophysiology is there is a normal bone mineralization. So whatever the bone is present, it is normally mineralized. Reduced bone mass, it causes fractures with trivial trauma, and the types are the osteopenic in nature. Now, what are the causes for osteoporosis? The causes for osteoporosis is sterility. So with increasing age, with postmenopausal osteoporosis, then post-immobilization, that is bedridden patients, prolonged fasting, nutrition, that is malnutrition or protein deficiency, and endocrinal Cushing's disease or hypothyroidism, and drug-induced long-term steroids can lead to osteoporosis. Then the clinical features, it is asymptomatic until the complications occur. The fractures are seen with traumatic trauma. The most common is the dorsolumbar spine is seen in adults, Colles fracture in elderly, and a neck of femur fracture is also seen. And the next is the radiological features. In the radiological features, there will be loss of the vertical height because of the vertebral collapse due to osteoporosis, or there is a cold fish appearance because of the disc bulging out of the vertebral body. A ground glass appearance can be seen. Sinks index is the one where we grade the osteoporosis from 1 to 6. Then other investigations will be biochemistry, where we look for the markers like serum calcium phosphate and the ALP levels. These are normal in osteoarthritis. Albumin levels or protein levels may be low. Densitometry or the DEXA scan is the gold standard for the diagnosis, and bone biopsy is rarely needed. Now the treatment, the medical treatment, it consists of a high protein diet, calcium supplementation should be taken, androgens or estrogens. It has got anabolic effect. Then vitamin D increases the calcium absorption. Alendronate or solendronate, it is the bisphosphonates. They are taken empty stomach, and they should not be anything that should be eaten after 30 minutes because there is a risk of esophagitis. Calcitonin can be taken. Teriparatide, which is a recombinant parathormone, can be taken, and denosumab or strontium granulate, which are LPS of THS, this can also be taken for osteoarthritis. Then the orthopedic treatment is weight bearing. It stimulates the bone formation, and ash brace or Taylor brace is used for preventing the pathological fractures in the spine. Next is the PIVD, that is prolapsed intervertebral disc. So the prolapsed intervertebral disc is nothing but the herniation of the nucleus pulposus through the annulus fibrosus. At the top of the intervertebral disc, it consists of in center nucleus pulposus, and outer one there is annulus fibrosus. The most common site is L4, L5, and L5 is one of the lumbar spine. Cervical spine C5, C6 or C6, C7 is common. Then pathophysiology, there is a loss of water content leading to disc degeneration. Then there is a prolapse, that is the nucleus it bulges out through the annulus. Exclusion, the nucleus escapes out. At sequestration, that is fragmentation free in the canal. Then clinical features, when the lumbar disc collapse, there will be low back pain, often with lifting or twisting. Then sciatica, sciatica is a radicular pain that is radiating to the buttocks. L4, L5 is one distribution. Then numbness and tingling, that is paresthesias, motor weakness, and cauda syndrome. Cauda syndrome is bilateral sciatica with saddle anesthesia and gallbladder involvement, which is a surgical emergency. What are the tests that we can perform? The straight leg raise test is positive. That is, the pain is radiating below the knee when we raise the foot at less than 70 degree. Straight leg raise test when pain on lifting the opposite leg. Then femoral stretch test is positive in L2, L3, L4. Motor deficit is present in the L5 region in extensalis longus. Sensory deficit along the medial leg, the dorsum of the foot, and the lateral foot. And knee reflexes like the knee jerk reflex or the ankle jerk reflex is diminished. X-ray of the spine will be normal. MRI is required, which is the investigation of choice that shows the disc herniation, the nerve compression. The CT myelography with the MRI is contraindicated. Differential diagnosis for this is lumbar spondylosis, spinal stenosis, or the tuberculous spine, TB spine. The management for this is bed rest for 2 to 3 days on a firm mattress. Then pain relief analgesics, reduce the spasms, that is muscle relaxants are given. McKenzie exercises and resistant cases. Then surgical indications, emergency surgery is seen in case of cauda equina syndrome. Also in severe neurological deficit, those who are not managing with medical or conservative treatment. Surgical procedures, they include the microdiscectomy, that is a small part of the disc is removed, laminectomy, or endoscopic discectomy. In cervical disc prolapse, it is common in C5, C6, and C6, C7 region. There is a neck pain that is radiating to the arm. The root compressions, C6 will lead to pain in the thumb and C7 in the middle finger. And then management is a cervical collar or Philadelphia collar that is used, and surgery if there is a cord compression. And the last topic, that is amputation. So what are the indications of amputation? It's a dead limb, that is gangrene. Deadly limb, that is bed gangrene, cellulitis, AV fistula, right, osteomyelitis. Or it's a dead lost limb. Dead lost limb, that is where there is a severe wrist pain, paralysis, contracture, right? There's a dysfunctional limb. Then the local amputation that includes the digits, that is done in diabetes mellitus. Ray excision is for metatarsophalangeal joint, and transmetatarsal amputation is done in case of severe toes are involved. Several toes are involved. The amputation is either above knee amputation or below knee amputation. Above knee amputation is greater healing, and the stump plane that is should be taken is at least 20 centimeters, and this should be done if the femoral pulses are absent. Below knee amputation, but however provides a better knee mobility, and stump should be more than 8 centimeters, at least 10 to 12 centimeters. Complications, early complications and late complications. Now, complications of the amputations. So from outside to inside, in the skin it will lead to Douglas ulcer. The scar because of amputations painful. Flap necrosis. The subcutaneous tissue will lead to abscess. In the muscles, contracture. In the arteries, it will lead to hemorrhage. In the veins, DVT. In the nerves, it will lead to neuroma or phantom limb. Then in the bones, it will lead to osteomyelitis. In the joints, it will lead to arthritis. Apart from the depression and social and economic problems will be present. Then the gait of the amputation patients is the amputee's gait. So basically what is amputation is a dismemberment of the limb or the part of the limb along with the circumference, including the bone muscles, resulting in functional loss and the disfigurement of the limb. So it's a dismemberment of either the whole limb or a part of limb, and there is a loss of function and disfigurement. The types of amputation: surgical amputation. There is a medical amputation because of certain drugs causing gangrene or frostbite, accidental in road traffic accident or machineries, and congenital amputations in amniotic band syndrome. Now there is skin flaps. There are single skin flap or double flap. Then shorter flap, it is used in shorter flap is the one that is broader at base. Long flaps are used in below knee amputation. It is taken from that compartment which has the maximum bulk. For in case below knee amputation in knees, in the legs, if we talk about the compartment with maximum muscle mass is the posterior compartment. So the skin flap is taken from the posterior compartment. The length of the flap should be at least 1.5 times the diameter of the limb at the site of amputation. Then the open stumps. The stumps are kept open in case of guillotine amputations. In guillotine amputation is generally done in case of children. It is contraindicated in adults. It is easy and safe to perform. Doubtful when the vascularity is present, however. Then the types of amputation: ray amputation, that is done at where multiple phalanges are involved, metatarsophalangeal incision, tense racket incision. Then Gillies is called as transmetatarsal, or tarsometatarsal is going to be the Lisfranc amputation. Chopard's amputation is the mid-tarsal. So ray is metatarsophalangeal, transmetatarsal is Gillies or ray excision. Then there is going to be Lisfranc, wherein there is a transmetatarsal and tarsometatarsal, and in case of Chopard's it is mid-tarsal. And Simi's disarticulation is of the ankle disarticulation. Below knee is also called as Burgess procedure. This is the most common. Then peg leg, that is 3 cm below the knee. Then grit strokes, it is done transcondylar where the patella is preserved. Above the knee amputation where long anterior flap is present. And hip disarticulation and Taylor's procedures where hemipelvectomy is done. And apart from that, other classifications amputations is based on the type, emergency or elective amputation, end bearing or non-end bearing. Then on the based of stump, closed stump or guillotine, open stump, that is guillotine amputation. And based on the procedure, it's a definitive amputation, provisional amputation. And ideal amputation stump. The stump length should be adequate. It should be broad-based, conical in shape, smooth, rounded. The skin should have adequate tension. And there is it should be mobile over the deeper tissues. The scar should be thin and should be painless in nature. And the proximal joints, there should be full range of motions over there. In upper limb, there is transphalangeal amputation, transmetacarpal, and then transcarpal. Then the wrist disarticulation. Apart from that, in the forearms, there is a Krukenberg procedure where fork-like reconstruction is done. Then elbow disarticulation, transhumeral or shoulder disarticulation. So it just has the normal direct names, unlike in case of leg, where the first is going to be the digit amputation, then the ray amputation, that is metatarsophalangeal, then transmetatarsal, that is Gillies, tarsometatarsal, that is Lisfranc, and Chopard's, that is mid-tarsal. After the amputation is done, there is going to be prosthesis. So prosthesis in the lower limbs, in the ankle there is a semies prosthesis, which is made up of plastic. Then such, that is solid ankle cushion heel, that is where the inversion and eversion are not possible. Jaipur foot, which is made up of rubber, it is best. It consists of dorsal flexion, plantar flexion, as well as inversion and eversion are present. Then below knee amputation, patellar tendon brace is used. For above knee amputation, the conventional prosthesis is used. Hip disarticulation, Canadian prosthesis is used. Physiotherapy or the occlusion therapy is provided. MES score, if it is, that is manual extremity severity score is more than equal to 7, then amputation is done. Prosthesis is an orthopedic rehabilitation device which is used internally or externally to replace the normal body part, while implant is used only internally. Then you have to remove the prosthesis every 6 hours, lubricate, wear the socks, and wear the prosthesis again. Dressings that are used in amputation, there are soft dressings which consist of soft gauzes. This is used for ulcer. Regular change is needed, and there are maximum chances of joint contracture. A soft dressing with a splint, it prevents the contractures, while the rigid dressings with plaster cast, they help in edema control, pain control, but no contractures takes place, and it is easy fit for prosthesis. The revision surgery. So the revision surgery, there is contracture, it is done for contractures. If there is infection, flap necrosis, or prosthetic unfitting takes place.